we'll kind of plow in. I hope you'll be gentle with me on the technology because this is all new to me. Right, so hopefully you can see where we're headed here. I wanted to start off just by talking about how we interpret clinical pathology in general, and always it has to be in the context of the clinical findings. And this is particularly true in liver disease, because liver disease can present with a whole variety of findings, and we have some signs which are relatively non-specific, as I've listed there. And then we have other signs that perhaps are rather more suggestive that we're dealing with hepatic disease specifically. But you can see, looking at that column on the left-hand side, there are a whole variety of things. That's an enormous differential diagnostic list that would also include liver disease. And because of this phenomenon that we'll have these secondary changes going on elsewhere affecting our tests, it does make it difficult for us to work out whether we're dealing with primary liver disease or not. So if we think of some of these other conditions that can affect the liver, you can see the list is extensive. But the common ones, or the most common ones that we probably see, are sepsis, gastrointestinal disease, cardiac disease, and pancreatitis, and potentially the other endocrinopathies that are listed there at the top. All of these will affect the results, but these induce what we call reactive or secondary hepatic changes. They're not the primary cause of the animal's clinical problem. The liver is just simply affected as part of the disease process. So in practical terms, when we start to approach our diagnostic approach to liver, we start, as always, from our clinical signs and the differential diagnostic list that flows from that. We then undertake our initial evaluation and look at those early blood tests, the kind of panels that we use all the time. I'm sorry, I've got an additional thing on my screen I'm trying to get rid of here. So we do our basic blood tests in order to look at liver enzymes, the common ones that we use, and we'll talk more about those in a moment. And on that basis, we can start to get a bit of a feel for, are we really dealing with a liver problem or not? But often those findings are relatively non-specific. We don't actually really know whether we're dealing with primary hepatopathy or not. And from there, we then have to move into function testing the liver, and we'll talk about the function tests that we can use. And B, we often have to simply enter a cycle of saying, well, let's look and see if there are any of these extra hepatic conditions that can be affecting the liver. And if we can identify any of those, treat those, and then come back to the liver changes that we saw and see whether they've resolved or not. If they're persistent or progressive, we have an increasing index of suspicion we're dealing with liver disease. From there, we may well consider some kind of imaging, and maybe allied to the imaging, we'll be using cytology if we've got kind of focal liver changes that we can have a look at. But if all of that has failed to give us a definitive diagnosis, and usually, unfortunately, that will be the case, the bottom line with liver disease remains that biopsy is what we actually require to differentiate those diseases. It's still very much the case that we need the anatomy that the biopsy gives us so we can see the structure. And there are certain factors we can get there in terms of prognostic information and therapeutic information, which really only a biopsy can provide. And I think, in fairness, we need to kind of outline this kind of program to the clients when we're actually starting with a suspected case of liver disease, make it obvious it's not going to be a one blood test is going to give us the answer. We're going to have to work through this kind of progression as we go through. Okay, so in terms of the structure of the test that we're going, or the structure of the rest of this talk, I want to start off briefly by just reviewing a little bit of the liver anatomy and what matters to us clinically and from the point of view of the tests we use. Talk a little bit about liver enzymes, the function tests, the additional information that full blood counts can give us, and then talk about this differentiation of primary and secondary liver changes a little bit further, the thing that really poses a challenge to us. So just going back to the anatomy, the functional unit of the liver is the hepatic lobule, and this is basically orientated around a central portal vein, a central vein in the center of the lobule, and radiating from that we have hepatocytes. These are the liver cells that are actually bathed in two different blood supplies. First blood supply comes from the hepatic artery, and that's oxygenated blood, and that comes in a structure called the portal triad that sits at the outside of the lobule. And in that portal triad, we also have a larger hepatic portal vein. Now that's bringing blood from the abdominal organs, and that's the blood that essentially is being processed, detoxified by the liver. And now all that, those two blood supplies mix and merge and head towards the central vein. Heading in the opposite direction, we have the small bile canaliculae, the small structures that collect bile from the individual hepatocytes, and that flow radiates in the opposite direction. We'll talk more about that in a second. The structure of the hepatocytes, as I say, is in these columns and sheets, but the function of the hepatocytes varies in different areas along the hepatic lobule. And as their function varies, so we'll find also that their enzyme components will change, and also their susceptibility to different kinds of disease process will also vary somewhat. And that can be important, as I said, when we're starting to think about the histopathology, because that helps to define the kind of structures of changes that we actually see. But from our point of view, it means that we have different enzymes and different components in the test that we look at that are related to different areas of the hepatic lobule itself. Sometimes we can make those distinctions, sometimes it's all a bit of a blur, but it can be helpful when it comes through. So just a reminder that our total supply comes in from the small intestine, the large intestine, spleen, the pancreas, and the stomach, and so it's obvious that disease processes that are affecting any of these organs will feed back, and the liver will be the first organ that will actually bear the brunt of any metabolic derangements or inflammatory components that are coming in, or even infectious agents that are coming in, and obviously potentially also tumor cells that are exfoliated from any of these structures can actually end up back in the liver as well. Just to briefly mention about the bile canaliculae, as we mentioned, these are the small structures which gradually lead towards larger biliary ducts, and eventually will lead into the gallbladder. The structure of these is lined by a regular epithelium, and they've got little microvilli on the surface that will actually fan the bile along to take it towards the gallbladder. The process that we talk about when we talk about cholestasis is effectively impairment of that flow of bile, and that can either be as a result of some kind of mechanical obstruction, or it can be a functional process. But when we're talking about cholestasis, and you've probably heard people talking about cholestatic hepatopathies, it's the impairment of the flow of bile through that system that's running from the center of the lobular outlet that we're actually talking about. So let's look at the tests that we actually use in the diagnosis of liver disease. The common ones we're all familiar with, I guess. First one would be alanine aminotransferase, or ALT. This is an enzyme that's distributed within the cytoplasm of hepatocytes. And if the hepatocyte is leaking, or if it bursts, as is shown here, then that enzyme that's in the cytoplasm will leak out. And the concentration in the blood of that enzyme, which is a higher concentration within the cell, will actually rise. And that's the basis of clinical enzymology. What we're really looking for is markers of enzymes that are fairly specific to a particular tissue, and when that tissue is damaged or leaking, then we can correlate that with an increase in concentration in the blood. In hepatocytes, we also have two other enzymes that we commonly look at these days. One would be AST, and that's an enzyme which is distributed in rather less quantity in the cytoplasm within hepatocytes, but it's also associated with organelles within the hepatocytes, and specifically mitochondria. So when we see AST going up, it's reasonable to infer not only that the cell is damaged or leaking, but also that the organelles within the cell are damaged. In other words, it's a marker of more severe damage to the cell than just a cytosolic enzyme, an enzyme from the cytoplasm that can just leak out. The other enzyme that we actually look at in this context is GLDH. Now that's another enzyme that we find in hepatocytes, and it's almost exclusively found in the hepatocytes. And as we'll see, that can be quite helpful to us sometimes, because these other two aminotransferases are also found in other tissues, principally skeletal muscle. So I talked there about cells actually being disrupted and broken open by damage by any kind of damage, and in that context the enzymes can then leak out. But in reality, most of the time the damage is actually rather more subtle than that. And I put together here just a couple of pictures. This is picture to the left is essentially normal hepatocytes. This is how we see them cytologically, and the picture on the right is damaged hepatocytes. And you can see they're not kind of burst open. These are not dead cells. They've still got viable nuclei, and you can define a kind of cytoplasmic outline, but they're obviously not happy. You can see this vacuolation that's kind of developing, and it's this situation of altered metabolism that allows these enzymes to start to leak out. And the more severe the damage to the cells, potentially the enzyme AST would start to increase in that situation. But otherwise, when we look at increases in these enzymes, essentially what we're looking at is the number of hepatocytes that are actually involved. So very high numbers when you're looking at ALT and GLDH infer that very large numbers of hepatocytes are damaged, but it doesn't necessarily mean they're irreversibly damaged or are not going to recover. And it's important to bear that in mind. Some people get very frightened by very high numbers, but we'll see sometimes that can be very much a reversible change. But AST tends to correlate with more severe hepatocellular injury and can be useful. The other enzymes we use are the markers of cholestasis. This process I've talked about here of impaired bile flow, this little neat bow is supposed to represent an impairment of bile flow, and you can see how the canaliculi on the left are actually kind of distended with bile. Now, alkaline phosphatase is actually distributed within hepatocytes, the lining membranes of the lining aspects of the hepatocytes that abut onto the bile canaliculi, whereas GGT, the other marker we use, is actually within the biliary epithelium itself. It's actually in this sort of slightly separate conducting system here. And we tend to use these two together to give us increased confidence when we're talking about cholestasis. So this is just an example of a dog that's got a severe pancreatitis. And as you can see, it's got a spectacularly high bilirubin, 351. And you can see here that the enzymes are doing pretty much what we'd expect. The alkaline phosphatase is very high. The GGT supporting cholestasis, because that whole biliary system is blocked up because of the swelling of the pancreas at the bottom there. The common bottom of the common bile duct, and that has gone up as well. But we can also see that hepatocellular enzymes have gone up in addition. And in this particular case, when we've had a paired sample, we can see that the bilirubin comes down very quickly once the pancreatitis is addressed. It's cleared very quickly. And as soon as the damage associated with cholestasis is switched off, the hepatocytes start to recover really quite fast. But you can see these other enzymes, alkaline phosphatase and GGT, come down more slowly, and proportionally their reductions are much less. And that's because these are induced enzymes. They're not released as a result of cholestasis. They're actually induced by the process of cholestasis within the cell, and their pattern of reduction is slower. Significant to that is that when you're looking at a resolving hepatopathy, don't worry if it takes longer for the GGT and ALK-Phos to drop than it does for the enzymes which are a consequence of release, because that's just the way they are induced enzymes, and it'll take a while for that induction process to turn off as well as to be turned on. If we start to think a little bit about the differences between dogs and cats, in dogs, they have a lot of intracellular ALT, whereas cats don't have very much. That means with the same level of hepatocellular injury, we'll see a much higher increase in ALT than we will do in a cat proportionately. In alkaline phosphatase, there is a marked difference in the half-life of that particular enzyme. In dogs, it's really long, it's 66 hours. Cats, very short, 6 hours. That means that for a cat to increase its serum concentration of ALK-Phos, it's got to be producing an awful lot of the enzyme very quickly in order to get it to increase in the serum level. So ALK-Phos in a cat, you'll notice that you see that relatively rarely. It doesn't mean there isn't cholestasis, it just means it's not very sensitive for the detection of cholestasis. So bear that in mind. You can still have cholestasis but have normal ALK-Phos and GGT in a cat. Conversely, if we do have an increase in ALK-Phos in a cat, we pay a lot of attention to that because it's a highly significant finding. The other reason that we tend to see a lot of high ALK-Phoses in dogs is that they have a different form of alkaline phosphatase. It's a different isoenzyme called steroid-induced isoenzyme. It's the same as the intestinal isoenzyme. In this particular case, that can be induced either by us giving steroids, or it can be associated with hyperadrenocorticism. But simply being ill and being chronically stressed will result to some extent in an increase in ALK-Phos. So mild increases in ALK-Phos are so common in dogs, partly because they're part of the dog's stress response. Just a couple of different aspects, not specific relating to enzymes, but in dogs it's normal for them to have a mild degree of bilirubinuria. I'm sure you've all seen that in concentrated canine urine. 1+, 2+ is not of any diagnostic significance. In cats, bilirubinuria is always abnormal. It's not a normal finding at all. And the nature of the disease processes we see tends to differ between dogs and cats. Dogs commonly, or their hepatopathies commonly center around the hepatocytes. It's injury to hepatocytes that is relevant, whereas with cats, it's more often that we see this ascending information coming back up through the biliary system often from the GI tract. That's the most common disease pattern. So I just wanted to show you an example of a cat with a cholestatic hepatopathy. This was a cat that we knew had a tumor, and you can see that although we do have an increase in alkaline phosphatase in this case, it's a very mild increase. This increase is so mild it would not be out of the normal range in a dog. So you do have to pay attention to the relatively mild changes in cats, alkaline phosphatase, and ALT. Similar, as we said, there isn't that much of it. And you can see that the gamma GT in this case, even though we knew there was a tumor there involving one of the liver lobes, there wasn't enough cholestasis to actually get that enzyme to increase at all. So you do need to have a sort of slightly different set of thresholds when you're looking at enzymes between dogs and cats. I wanted just to show you how dramatic the effect of steroids can be, and particularly this steroid-induced ALT phos. And you can see here we had two samples. The sample on the right is from Molly when she was first presented with, and you can see right at the bottom there, an incredibly low white blood cell count and also a very low platelet count. She had, after a bone marrow immune-mediated neutropenia and thrombocytopenia, and so the decision was obviously made to put her on immunosuppressive doses of steroids. So within really quite a short period of time after starting that steroids, you can see her ALT phos has gone up tenfold, and her ALT has also gone up. Our marker of slightly more severe hepatocellular injury gone up rather less, because steroids will induce changes in the liver, but there's no suggestion here that this is the liver that's going into failure at this kind of level. And you can see that GGT has also gone up because the hepatocytes have genuinely swollen and filled up, rather like the picture I showed you before, usually with glycogen. And so there is a degree of genuine cholestasis going on here. And you can see that that's helped her bone marrow condition enormously, but the liver has kind of paid the price. Now, the reason I show you this is I think it's very important when you're putting animals on immunosuppressive therapy to take the baseline data, because if you'd only taken that first sample when she came back on the 5th of May, it would be very difficult to know whether she genuinely had hepatic disease or not. And I think it's fair to say to clients, look, when we're starting out on this, we need to have a baseline, and then to record that baseline information. Simply saying the results are normal doesn't help. You really need to know what those values are, so you've got something that you can kind of compare against for the future. Just a word about the different kind of packages of tests that are actually on offer. And one of the things that's happened as a lot of lab data has been transferred from external labs to in-practice systems is, for reasons of cost, essentially, people are trying to limit the number of assays that are actually included in the package that they're running. And I think this is important because I don't think there's anything wrong with using screens, which are really these smaller packages that contain a single test for each organ or for each particular kind of abnormality. For example, in the liver, we use ALT as our marker of hepatocellular damage and ALT phos as our marker of cholestasis. There's nothing wrong with using those as long as we know that we're just trying to screen. We're just trying to find information that will tell us whether everything is normal or not. But when we're presented with an animal like our original list, which has clinical signs that could relate to primary liver disease, they probably don't really give us enough information. And we need a profile, because a profile will use that complementary information, and we've already seen a couple of examples there where you use the different tests like ALT phos and GGT together, or AST and ALT together, to give you a bit more information about what's going on. And obviously that expands as we look at the other tests that we're going to cover here. Now, a well-designed profile should help you to narrow down the differential diagnostic list. It should allow you to say, well, this looks more likely, this looks less likely. Frankly, a screen usually can't do that. It can simply just give you a yes, no, is it normal, is it not abnormal, is it abnormal? And I think we've got to be careful here that we don't, in the process of trying to offer speed, necessarily lose a lot of that qualitative information, that additional information that a profile can provide. And in the context of liver disease, we're lucky here. We're dealing with a disease that's usually relatively chronic, so it's not a problem to do that. So this is just an example of where a profile picked up an abnormality that you wouldn't see if you just ran a screen. If you screened this dog and you just had ALT, you'd say, we've got a very marginal increase in ALT. Could be hepatic disease, but equally could just be reactive and not of any significance. Everything else looks fine on that screen. Introduce the bile acids, our marker of liver function, and suddenly we go, oh, that's a moderate introduction. that's a moderate increase. And in the context of a dog that was presented with a personality change, dull and uninterested, that is a significant finding, and we should follow that up by doing a bile acid stimulation test. So sometimes just pausing to decide which is the right panel to go is before we start, and not doing the automatic choice is a decision worth making. So I wanted to show you one of the other aspects of profiles, and that is that they nearly always include hematology. This was a dog, this was a Springer Spaniel that had a benign tumor removed about 10 days previously, had some antibiotics and was sent home doing fine, and then presented suddenly with pyrexia, anorexia, brown urine, and was collapsed. And if, as sometimes happens, we'd looked at this just as a biochemical panel, it would be tempting to sort of think, well, this dog has clearly got some evidence of renal insufficiency. We seem to have very high proteins, and we seem to have evidence of increased hepatocellular damage. Again, at a screening level, we would simply say, well, it's a mild increase in ALT. We look at AST, though, we would start, to become considerably more concerned. That's a marked increase in AST. And the GLDH is supporting that there is some mild increase in hepatocellular injury going on here. So these three, all pointing towards hepatocellular damage, but to a different extent. Mild increase in basal bile acids at this stage. But the key to this case is not actually in the chemistry; it's in the hematology, because what was happening here was we had a severe anemia. It was highly regenerative, and it was strongly Coombs positive. So what was actually influencing the hepatocytes here was the fact that, in fact, it was a response to hypoxia because of the presence of an immune-mediated hemolytic anemia that probably, in this case, had actually been triggered by the antibiotic therapy that had been given post-op. So just a reminder that although we talk about chemistry, we're always trying to interpret it in the light of the hematological findings at the same time, and we can be misled if we miss out on the hematology. So our kind of golden rules for investigation of liver disease is it's fine to screen on ALT and ALT-FOS if you don't have an index of suspicion for liver disease, but if the profile or the clinical signs could reflect liver disease, then we need to be more suspicious of liver disease as a possibility on this. Then it always has to be a profile. And remember to take those baseline samples, and I think we just need to talk owners through and sort of say it's going to be very hard to work out what's really going on if we don't have some baseline data here. And it's helpful if you've got an information system that will help you to manage that lab data. But it's, I think, a major problem which I speak to people all the time on the phone, and I say, well, what were the results? And they say, well, they were normal. And that's simply because the data hasn't been preserved. And that seems like we're throwing out the really good bits there without hanging on to them. And I think that's a takeaway from tonight, is have a think about that. If your system only records the abnormals, we're losing the good bits that we want for future comparisons. So the point of this slide is actually not the cat. It's actually the dial on the washing machine. It's just to remind you that we all have these multiple options, and most of us by instinct will go for one or two. But when we're thinking about liver disease, sometimes it's worth just stepping back and thinking, well, actually, is my default setting the right thing to do, or should I actually think about including some other tests at the outset? Not least because it will almost certainly be cheaper to do things like add a postprandial bile acid onto a profile that already includes bile acid than to do that separately or such. Okay, moving on from enzymes to bilirubin. And just a reminder really of the biochemistry of this, in that, as we've just seen, bilirubin starts its life with the hemolysis, with the breakdown of red cells, and the transport of unconjugated bilirubin back to the liver, where it's absorbed into hepatocytes, conjugated, and then excreted into the bile canalicculus, which ends up in the gallbladder, passing down the common bile duct into the intestine, where it's broken down either into stercobilinogen or urobilinogen. Just a reminder of that's the normal mechanism. And as we said in the dog, there's a very small amount of conjugation goes on in the kidney, and we find a little bit of bilirubin coming through in the urine as well. So that's the normal system that we're looking at. Obviously, when we're starting to think of increases in bilirubin, then we can either see this as an increased production of unconjugated bilirubin. We can see it as a consequence of the failure to clear the bilirubin from the circulation because the hepatocytes are either diseased or not present. We can say in the context of cirrhotic liver disease, where we've just got no hepatocytes left. Or it can really be a kind of mechanical problem with the excretion of bile down the common bile duct and in the biliary system. And we've already seen the example of that with the pancreatitis, where the problem there was that simply the bile could not actually leave the liver. So in terms of measuring bilirubin then, or when we look at a dog with an increase, or a dog or a cat with an increased bilirubin, we've really got to say, are we looking at a problem here of increased production of bilirubin, a problem with uptake, or a problem of excretion? And our diagnostic approach initially is to do the full blood count to exclude the pre-hemolytic or pre-hepatic jaundice associated with, usually with hemolysis and very rapid destruction of red cells. And then our problem becomes, are we dealing with an intrahepatic problem or a post-hepatic structural problem within the biliary system? And I'm sure we were all told a long time ago that we could measure direct and indirect bilirubins. Utter waste of time. Don't bother, it just doesn't do it. Ultrasound will give you a much better picture as to whether we're dealing with an obstructive problem. So this is an example of another aspect that we sometimes see in clinical chemistry, and it's just to kind of bring it to your attention really. This was a diabetic cat. Max was a diabetic cat. You can see that from his fructosamine result and his glucose. And this was him at the point of diagnosis. And you can see that his bilirubin was apparently increased, and that raised a current concern in our minds about, could he actually have a concurrent cholangitis or a pancreatitis or be developing hepatic lipidosis? All of those were kind of on the list because of that increased bilirubin. But when we actually looked at the sample, there was no visible icterus at all. And usually at about that level, you would be able to start to see that the sample was actually looking yellow, and we'd actually pick that up. But what we did notice was that the sample was extremely lipemic. This is the lipemic sample here on the left, and you can see you just can't read fine print through that at all. It's completely creamy. This is just a normal sample for comparison. And what I'm really alluding to there is the fact that all analytical systems will be affected by the quality of the sample that go into them. And here on the right, we've got some normal serum. This is a lipemic and hemolyzed sample in the middle, and on the left we have a sample that's hideously hemolyzed. And in this particular situation, and using the analytical system that we use, the presence of marked lipemia will increase bilirubin somewhat. And you need to be aware of those effects, because if you've passed the sample on to somebody else to do the analysis, particularly in your practice lab, and they don't tell you that it's lipemic, then there's no way that you're going to know to interpret your data appropriately. And I think that's a bit of a take-home as well. When you take on in-house analysis, you're now responsible for that aspect of sample quality management. And there needs to be a system of feedback so that you actually know whether the sample quality is affected. The second thing you need to know is obviously which of your assays are affected and how they're affected. And for that, you just need to go to the manufacturer of the kit and say, well, what's true for your system? And if they tell you they're unaffected, I would suggest that they probably have incomplete information. Let's just leave it at that. Okay, just to perhaps look at a slightly different aspect of the same issue. If you remember our spaniel with the immune-mediated hemolytic anemia that had a pre-hepatic jaundice, and indeed the sample did in fact look yellow to us as well, you can see the bilirubin here came out as almost undetectable. And yet this animal was passing brown urine. We knew that there was in fact an increase in bilirubin. Why is that? Because of the hemolysis. Those cells were falling apart so quickly that they were actually hemolyzing within the serum itself. And the effect of hemolysis is that it will inhibit bilirubin assays in some analytical systems. So these effects can be quite significant. If you just looked at that as a panel of results, you'd think, this makes no sense to me. You have to know that bit of information about the sample quality. So that's probably a bit of a take home there. And in fact, part of the reasons why these proteins are so high is probably also an artifact associated with hemolysis as well. So this it's just to look at a sort of slightly different aspect here then so we've looked at essentially a pre-hepatic jaundice, and we've looked a little bit at sample quality issues. Now I wanted just to look briefly at an intrahepatic jaundice. And here we can see we've got high bilirubin, we've got evidence of cholestasis from our ARC-FOS and our GGT, and evidence of increased hepatocellular injury, all going on in a dog that presented with an acute onset pyrexia, and it was an older dog. And we also had evidence of multiple organ involvement. You can see there are some marked renal changes here as well. And the point here is that very often it is difficult to work out which came first. Is this really a problem of primary hepatocellular damage with secondary swelling causing cholestasis? Or is it a problem really of cholestasis with secondary effects on the hepatocytes? It's very often difficult to tell, and it's often mixed. It's very difficult to characterize that completely. But in the context of recognizing the clinical pattern here, when we see multi-organ disease, as we've clearly got here, we should be thinking is there some kind of underlying systemic cause rather than an individual cause. So it could be something toxic, or it could be something metabolic, or it could be something infectious. In this particular case, that's an example of a leptospira that's actually causing both renal and hepatic changes. So going back briefly to our example of Bramble with his pancreatitis and his very high bilirubin that we looked at earlier on, just notice here how high his bilirubin is. The highest bilirubins you will see are associated with conditions which are affecting the biggest biliary vessel, and obviously the common bile duct is the biggest of those. So when you see very high bilirubins, start straight away to think, maybe I should be imaging this because I may well see something going on further down the biliary system, not necessarily inside the liver, but beyond the liver. And I think that gives you a bit of a clue. So bilirubin, say, over about 150, 170, maybe even over 200. At that stage, I'd be starting to think, I think there's likely to be a component here of cholestasis that may be involving large biliary vessels. And as we've said, don't be scared by large increases in liver enzymes. You can see that ALT and AST doesn't mean it's necessarily got a poor prognosis, just means lots of cells are affected, and you can see quite quickly that's starting to settle down. So this doesn't carry a bad prognosis by any means. If we can resolve the cholestasis, things should work out absolutely fine. This is really just an illustration of the kind of things that can cause these extrahepatic bile duct obstruction. It could be pancreatitis, it could be a pancreatic tumor, it could be another tumor of the biliary system, that all have the same effect, damming bile back, and so we see a big release of alkaline phosphatase and a secondary release of ALT. So our golden rules for interpreting bilirubin are, first of all, get the pre-analytical factors out of the way. That's the stuff that we talked about with hemolysis and lipemia. It's true of any test that you're undertaking. Get pre-hepatic disease out of the way. And then if we're seeing very marked increases in bilirubin, start to think of obstruction of large biliary vessels. Sometimes we'll also find that you can have a mild increase in bilirubin that you can't see. Don't be surprised at that. Sometimes hard to see when the concentration's less than about 30 micromoles per litre, but still above the top of the reference range. And remember that if you have cholestasis going on in very small biliary vessels, the serum bilirubin doesn't go up at all. You'll just have to see that reflected in increases in GGT and alkaline phosphatase, because the rest of that bilirubin will be dealt with by renal clearance. So if we then think about the function indicators that we commonly use, the liver produces an enormous number of carbohydrates, proteins, and other metabolites, but the ones that we commonly measure are the ones listed on the left there. And so we can use these to try and give us a bit of a clue as to whether the liver is functioning normally or not. So on the right here, we have chemistry from a Staffordshire Bull Terrier, Roxy, who was presented originally with a pattern of bile acids that was clearly compatible with having a portosystemic shunt, and it went for imaging, and that was confirmed. And look at what happens at the parameters that are actually produced by the liver. We've got a very low albumin, a reduced urea, a low cholesterol, and we've got some evidence of hepatocellular damage, but the significant findings here are the fact there's clearly impaired function. When Roxy then went for surgery and had the shunt vessel effectively closed down, she then came back sort of 3 months later, and you can see that once we've started to perfuse the liver with that portal blood properly and the hepatocytes are working properly, then there's a dramatic improvement in these parameters. So this is quite a powerful tool for us, which is called reductions in the endogenous function indicators, fairly specific for presence of significant hepatic functional impairment. And you can see, as I say, that's reflected in the bile acids. And you can see this is a spectacular shunt repair because we've done very nearly got the bile acids back to normal. Just a brief word about the hematology in Roxy. One of the other things that's actually affected in dogs with shunts is iron metabolism. And one of the patterns that you'll sometimes see is that these animals will have a reduced MCV, microcytosis, small red cells, despite not having an anemia. If you see that pattern, I would start to think liver disease. And you can see that that change persisted even though the anemia actually resolved. That's also true of a lot of shunt animals. They often completely metabolically don't go back to entirely normal, and that could be quite a little useful footprint. You'll also see that change sometimes in cirrhotic liver disease as well. So if you see microcytosis in the absence of anemia, it's well worth having a look at the liver. The other factors which are produced by the liver are the factors involved in the coagulation cascade, and those that are, with the exception of factor 7, all of the coagulation factors originate from the liver. So basically, it's no surprise that if we have liver disease and impaired hepatic function, we will see reductions in the levels of these factors, and eventually that will be picked up by the fact that the times that we measure, which are correlating with these factors, will start to increase as the amount of the factor actually goes down. Now, this is particularly pertinent in cats, and we have two different patterns you see there. The first is that it's common that we see mild increases in PTT, that's the test that actually looks at the intrinsic and common coagulation pathways. Those times often go long. But the issue that then arises is, well, is it so long that I shouldn't actually do my liver biopsy? And the honest answer is, in a cat, if you have a PTT of less than 100 seconds, yes, it's not normal, but the cat usually won't have abnormal hemostasis during the procedure, and we wouldn't necessarily see that as a contraindication to going ahead to do surgery. So longer than 100 seconds, I would think twice about it. The other pattern we see in cats is where if the bile duct is effectively blocked, there's extrahepatic bile duct obstruction, the bile is not able to escape into the intestine, and therefore we don't get very much absorption of fat-soluble vitamins, because that's one of the functions of bile, is to assist the emulsification of fats. And these animals effectively run out of vitamin K, particularly also if they've been on antibiotics and we've been reducing or altering the normal bacterial flora. So in these, we'll see an increase both in APTT and PT. And it's well worth looking out for that pattern, because in that situation, I wouldn't go ahead and do surgery until I've corrected it. And it is correctable because we can actually give vitamin K. So this is a case Luna, and you can see it's a complex panel, but I want you just to look at the PT and PTT and see that in this particular case, both the PT and APTT were abnormal. And we said, no, on this situation, we'd rather give vitamin K and give the animal 24 hours and then reassess this before we went ahead to do any kind of surgical procedure. So reductions in endogenous function indicators, they only occur with marked hepatic disease. Therefore, you can still have significant hepatic disease and they won't be affected. But if you do see them, they do support the idea you've got significant primary liver disease. And we'll always try and support that by using a bile acid stimulation test to show that hepatic function is significantly affected. Don't forget also that as one of our function indicators, we need to check coagulation factors, and that's particularly important in cats, more so perhaps than in dogs. So bile acids are other tests that we use of liver function. Essentially, bile acids made from cholesterol in hepatocytes, excreted into the bile, and then in response to a fatty meal and the release of cholecystokinin, those bile acids are released through the common bile duct into the small intestine, where their job is essentially to emulsify fats. And the complex of the bile acid and fat comes back in the portal circulation, and those bile acids are reabsorbed. So the amount of the bile acids that are going back into the peripheral circulation when we take our samples is generally very low indeed. If we have an animal which has got impaired hepatic function for any reason, then that recovery process of the bile acids, that clearance of the bile acids, is reduced, and then we start to see higher concentrations of bile acids in the peripheral blood. So this is an example of another dog with a shunt, and you can see that again we've got a couple of our function indicators are actually reduced. He's got a low albumin and a low urea, and you can see that he's got high bile acids right from the word go, and they don't stimulate that much more when we give him a fatty meal and ask his gallbladder to contract. And in fact, the degree of contraction in the gallbladder is actually very variable in response to a fatty meal. It's somewhere like 15 to 60% of the retained bile is actually released. So there is some variation there, but it does give us a better look at the liver than just a basal bile acids on its own. So just to be aware that when you're looking at animals with shunts, this is our dog that we looked at before that went for surgery, be aware sometimes that if the dog has been fasted for a fair period of time, they can in fact clear bile acids. So although some shunt dogs will have a high basal bile acids, in other dogs you'll actually have to look at postprandial bile acids to be able to show that they've got a really spectacular increase. So don't be tempted into thinking that in an anorectic dog, a mild increase in basal bile acids implies normal hepatic function. You do have to do the stimulation test to be sure. So bile acids then can be affected either because the hepatocytes aren't working properly, it can be because we don't have any hepatocytes left, either in the context of a shunt because the hepatocytes are just being bypassed, or it can be in the context of cirrhotic liver disease because we've got no hepatocytes left. Or our third possibility is that the blood is simply bypassing through other vessels and making its way back into the normal circulation. So that's our kind of default differentials for increased bile acids. It's reduced hepatic function, reduced number, or we've got shunting going on. So as we've mentioned, using the postprandial bile acids, where we've actually stimulated that system and forced the release of bile, hopefully, it will increase the sensitivity of detection of significant functional impairment. It's definitely the test we have to use for a shunt, and particularly be aware of that in cats, because in cats, basal bile acids, when in animals that were looked at that had shunts, basal bile acids sensitivity was only 49%. You needed the stimulation test in order to pick up the majority of the shunts. But we have some downsides, and that is that bile acids are influenced by all of these other disease processes that we've talked about that can influence the liver in terms of a reactive hepatopathy. And they can also be influenced by the presence of cholestasis. If the bile can't get out because there's an obstruction in the biliary system, the bile acids dam back and they'll leak back into the circulation, and we'll start to see very high bile acids in the peripheral blood. And for that reason, you've got to be very wary about using bile acids in any animal that's looking jaundiced, because it might be that all you're looking at with those high bile acids is not impaired function, but simply obstruction to the biliary flow. So here's a cat this time with extrahepatic bile duct obstruction. We know this because he had a laparotomy, maxillary laparotomy, to remove that. And just look how high the bile acids can actually go simply as a consequence of cholestasis. And that can be a very useful clue. If you get a bile acid that's coming back over 300, then start to think, is this extrahepatic bile duct obstruction? And put that together with the very high bilirubin that I talked about, that also you can see in extrahepatic bile duct obstruction. If you see either of those changes, then immediately start to think of change going on further down the biliary system. So if we compare how we interpret bile acids between dogs and cats, normal bile acids on a postprandial sample, usually less than 10, these are in units of micromoles per litre. We've got diffuse hepatic changes. In other words, if we took a biopsy, we'd see something going on. That would normally be associated with postprandial bile acids greater than 20 in the dog, a little bit lower in the cat, 16. And these reactive or secondary hepatopathies we've talked about, they can show quite marked increases in bile acids, up to about 100 and 120. And that poses a problem with us, because in some animals that will overlap with the bile acids that we'll see in animals that are actually showing clinical signs of encephalopathy. So you can have situations where you have quite difficult interpretations to make between, is it just a very marked reactive hepatopathy, or have I actually got significant impairment of hepatic function? Sometimes it's simply a question of ruling out those causes of reactive hepatopathy and re-evaluating that and comparing it back with the clinical signs. With cats, things tend to be a little bit lower, so up to about 90, that would be about as high as a reactive hepatopathy would go. But again, slightly lower, we'd still see cats with shunts that have got postprandial bile acids in the 80s and up. So they can help us, and we need those guidelines, or we need to have some kind of guidelines to be able to differentiate those possibilities. So in summary then, it's a very sensitive test for impaired hepatic function, but it's not specific for primary liver disease. It can be influenced by reactive changes. Stimulation tests are helpful, and I think it's worth using them. And it's certainly useful in monitoring bile acids and repeating a bile acid stim test if you're considering a biopsy. I'd certainly strongly recommend that. The last thing just to be aware of is that not all bile acid assays work the same or as good as one another. The picture on the right there is our biochemistry analyzer, which is an IL-650, and it spends an enormous amount of time and effort actually making sure that all of these assays actually work properly. Bile acids technically is a very difficult assay. It produces very, very fine color change, very marginal color change. So it's quite easy to get abnormal results if you don't have really good optics and really good laundering on the analyzer that you're using. And personally, I think bile acids are a test that's best to go out to get top quality assay, because you'll find that some of the reagents that are available for in-house use are really not that helpful. So on then to hematology, and we've really talked so far about how biochemistry defines the location of the changes, and to some extent the type of the change, and we can use it serially to monitor severity and things. But hematology gives us more of a clue as to why, why potentially the hepatopathy is there, and what's its underlying nature. So it may occasionally give us an etiology. Sometimes it'll give us nothing, but sometimes it'll give us a clue to chronicity, because we'll simply find there's a non-regenerative anemia there, suggesting that that's been there for a while, or that pattern I talked about before of microcytosis without anemia. And occasionally it will flag us up that something bad is happening in terms of other changes like the development of DIC, which can be a complication of liver disease in some cases. So this is just results from Whiskey, which is a young vomiting jaundiced cat, and you can see that his panel of chemistry is pretty much completely unremarkable apart from a very high bilirubin, and he was indeed quite jaundiced. But when we looked at his full blood count, we could see that we had marked changes in the white cells, and what we have here is a band neutrophil on the left, and you can see there's a blue inclusion in that cytoplasm. That's what a Doley inclusion looks like if you've not seen one before. And no doubt you've already seen hematology reports where people are talking about toxic changes. Well, the example there is of that kind of rather vacuolated appearance to the cytoplasm in the neutrophil. That's toxic change as well. And the cell on the right is actually an even earlier version of a neutrophil than a band neutrophil. That's called a metamyelocyte. And it implies that the bone marrow is having to churn out white cells very quickly. In other words, that there's a suppurative inflammatory response going on, a very acute neutrophilic inflammatory response going on. So in this case, if we put the two together of a high bilirubin with these white cell changes, and that's just the numerology, if you like, of Friskey's hematology, then we can start to get an idea that we may well be dealing with an inflammatory response that's going on within the biliary system, not so much affecting the hepatocytes. That's why we had normal hepatocellular enzymes and things like that. But we could see that there was clearly suppurative inflammation going on with obstruction to bile flow, and we can see that quite clearly when if you take a biopsy. This is a different kind of change where B presented with basically was pretty bright and happy, but was polydipsic. And on the panel, the only change that we had here was an increase in GGT. You can see in this case, OCT was completely unaffected. So that the interpretation we put on that is that this may be something that's actually involving the biliary system to some extent, rather more than the hepatocytes themselves. But of itself, again, it tells us where it is, but it doesn't tell us what it is. When we look at a blood smear, though, it's looking like mobile lymph node here. These are all lymphoid cells and lymphoid blasts in the circulation. And when we look at the full blood count, very high white count with a very marked predominance of lymphocytes that were abnormal in morphology. And this was an acute lymphocytic leukemia that was actually infiltrating the liver and, in fact, other tissues as well. So again, doing the hematology can give us that qualitative information as to what's the nature of the change that we're actually looking at. Now, obviously, these are, or certainly B is a relatively unusual example, but it's not that uncommon in animals with hepatic lymphoma that you'll find low numbers of circulating cells. Often not enough to necessarily be flagged up as a population here, but something that you'll see if you look at a smear. And lastly, on hematology, just to look at those acanthocytes, these are the irregularly spiculated cells, the cells that look like sort of spurs with these irregular projections that are pointing out. And these can be associated just with liver disease per se, but they can also be associated with DIC, and they can be associated with hemangiosarcoma. So these cells, if they're present, are highly significant, and they won't be flagged up by automated counts. It's only really when you look at the smear that you actually identify. So I think with hematology, there's been a trend to try and view it as numbers and to try and make it into another chemistry, but that's not really correct. I think it's better to think of it as cytology with added numbers, and numbers really confirm what it is that you've already seen. So if you're working in a basis where you just trust the numbers, you're probably missing the good bits. And perhaps a suitable analogy is a picture is worth 1,000 words, and certainly several thousand numbers, I think, in hematology. Okay, so to try and pull this to some kind of a conclusion, with differentiating the kind of hepatopathies we see, when we're thinking about primary liver disease, we're always looking for the supportive clinical signs. We're looking for documenting persistence of enzyme changes or that they may be progressive. And we're looking for these more specific two enzymes, AST and GDT, to help us. Variable changes in bilirubin. Sometimes we'll see endogenous function indicators are reduced, but the bile acids will usually tell us that function is abnormal. And often, if we then try and treat these, like we think there may be some other disease process going on, we'll find these changes simply won't go away. That's not true with reactive hepatopathies. Usually if we treat the underlying disease like gut disease, we'll find the liver changes will settle down. And the changes by and large tend to be slightly less severe, although as we've seen in some of these examples, there can be some overlap which makes it difficult. So lastly, just a few slides just on using cytology in liver disease. Yes, it's helpful. Is it safe? Yes. I'm aware of one dog that bled post-op after a fine needle aspirate, and it was already in DIC anyway. But otherwise, I think this is a safe procedure, and certainly in cats, it can be really quite helpful. And we'll just look quickly at an example of that. So what do we see? We can pull out these clumps of hepatocytes, and we have a fair degree of detail that we can actually obtain from that. This is a case we looked at earlier, which had got long-term vomiting and weight loss. He had multiple problems. But I want to point out to you here that, remember we've said that alk-phos doesn't go up very much in cats? Well, there is a pattern where it does go up predominantly way over everything else, and that's in hepatic lipidosis. So when we looked at this panel here, and we saw this massive alkaline phosphatase for a cat, in a cat particularly that's been anorexic and was weak, we were very suspicious of hepatic lipidosis. So in this case, we took an aspirate, and we can see, in contrast to those normal hepatocytes I showed you, these cells are completely blown out, and you can see this is actually the bile canaliculi. You can actually see them plugged up and filled up with bile. So this is actual real-life cholestasis that you can see here. So clearly, it's very difficult for a liver to recover from this situation, and as you know, the therapy for this, that's the histopathology from a different case, but just to show you how well the cytology compares with histology. So when we're dealing with hepatic lipidosis, we need early and aggressive nutritional management. And I think in that situation, cytology is a real must, because that will give you the fast turnaround. You can get the information quickly. And I'd certainly suggest if you've got suspected hepatic lipidosis, do a cytology, look at it yourself, or send it to a lab that will give you a fast turnaround on it. The other condition where cytology is very helpful is in the diagnosis of lymphoma. We've got a nice mitotic figure in the center of this field with a whole bunch of lymphocytes round about, to the exclusion of normal hepatocytes. These are red cells you're seeing in the background, not hepatocytes. But things can be more difficult with cytology when we start to deal with other disease processes in the liver. And I think it's fine to do cytology, but I don't think it's a substitute for histopathology. This is lymphocytic cholangitis in a cat, and you can see if you stuck a needle into this and you happen to hit all those lymphocytes, it wouldn't be difficult to get a false positive diagnosis of lymphoma from that. But it is important to recognize that sometimes you have to take care and know the limitations of the technique you're using. Another situation where we have problems with cytology is in terms of nodular hyperplasia. And here you can see there's a lot of anatomy going on here. We've got cores of regenerative hepatocytes going on, surrounded by connective tissue. Cytology can't really get a handle on this, and I wouldn't recommend that you try to use that. So liver cytology has its strengths, it's got its advantages, it's fast, I think it's safe, fabulous for hepatic lipidosis, and useful in neoplasia, but don't expect that it's going to do too much, and I think it's fair for it to be a step on the journey, but it may not be the end point. And importantly, it might miss that prognostic information that you need for the future that only a biopsy can give. And lastly, obviously, unfortunately, it is operator dependent. It's well worth practicing on some cadavers. And if you like, just send them in and we'll look at them and just tell you whether the sample quality is good enough. So to come back to some extent to where we started, that we're working through in our liver cases, clinical signs, those initial tests, and I hope from what we've talked about tonight, you've got a much better understanding of how all of those tests kind of work and fit together. We're then going to look at liver function using the bile acid stimulation test, some of the other tests in our profile. We're certainly going to sometimes think in terms of imaging. I'm no expert to tell you about imaging, but it can be very useful and it can help you guide your fine needle aspirates to focal lesions. And I think for focal lesions, cytology is good. But remember, the bottom line may well be that we need to consider biopsy. A number of different techniques and a number of different ways of taking biopsy. I'm not going to go into that here. But just to finish again, more or less where we started, here's a normal bit of liver and here's our central vein. Here's the hepatocytes radiating out from that. Here's our portal triad with our biliary vessels in bringing in the portal circulation, and in this case lined by biliary epithelium. This is the collecting point for those little canaliculae as they then make their way back towards the gallbladder. So we have a nice clear structure and we can see everything that's going on. When we look to the right, a case of cirrhosis, then you can see how complex the structure is. And here you need the histopathologist to guide you for particular features, which are going to tell you this liver is likely to get better, not likely to get better. And unfortunately, the ballpark remains. We need to gear up for liver biopsy at the end of the day. So to try and pull that together, then we start off by considering, is primary liver disease likely? We need to choose an appropriate profile, including a full blood count. And if we find liver changes there, we need to think about, could this be a consequence of extrahepatic disease, these reactive or secondary hepatopathies? And if so, we need to treat them and then come back and look again. And then thereafter, look to document persistence and progression. Cytology's got a role, but it's not a substitute for a biopsy. And sadly, that's where we may necessarily end up in some of these chronic cases. Okay, this is my border terrier who unbelievably has a cholestatic hepatopathy, but this was her just sleeping peacefully under the duvet, and I think looks like we're about on time, and I'll pause at that point, and I'll be happy to answer any of your questions.
Great. So let's see if we got any questions coming up. Right. Hello, Nick. Is there a cutoff value for bilirubin that would make biliary obstruction likely or unlikely in dogs or cats? And that's a question from John.
Yes, I think the figure I mentioned actually was probably at about 250, but certainly anything over 300, I think it's got major bile duct obstruction until proven otherwise when it's over 300. So take 300 as your kind of your home and dry. It's got to be in the large biliary vessels. Nothing else will get that high. It has to be obstruction that's actually making the bilirubin go that high. And that would be true of the dog and the cat. But also remember that other case I showed you where actually very, very high bile acids, by which I'm talking over 300 again, use that same number, over 300. There aren't that many things, there aren't that many conditions that will make bile acids go that high. Almost invariably that will also be a consequence of cholestasis and usually obstruction of the common bile duct.
Great. Lipemia, you said, could increase bilirubin levels, but it would never be to that level.
Exactly not. No, not at all.
Okay.
Nothing like.
Great.
Sorry, I just wanted to, just while we're chatting.
Right. Yeah, you want to get something up. Okay, great. I'll get you the next question, which is, what do you suggest for adult dogs who have a repeatedly high postprandial bile acid stim test with normal, slightly raised basal levels, but no evidence of other biochemical changes?
Well, actually, to some extent, it depends what kind of breed they are. Some of these individuals will actually have a form of shunting, which is called microvascular dysplasia, and maybe Mike Willard talked about that, where you have very small intrahepatic shunts that are actually going on. So the blood is flowing through the liver to some extent, but some of the blood is actually simply bypassing the normal hepatic structure that we looked at, and just making its way back into the portal circulation. So in the little breeds, Shih Tzus, some of the terriers, things like that, if the dog is well and there's nothing else going on, then microvascular dysplasia would be one differential. Another possibility could be that it's got a low-grade reactive hepatopathy. Maybe it's got mild gut disease, might even just have dental disease or something like that. just enough that there is mild metabolic derangement and the bile acids will go up a little bit. They're an extremely sensitive test. And again, if you're up in the sort of 30s, 40s, it's been stable, the dog's fine, I wouldn't rush to do any invasive diagnostics on that, to be honest with you. I think it's when they did the original work on bile acids many years ago now, they found, although they defined a reference interval as less than 10, they were perfectly normal dogs in their normal population who had postprandial bile acids going up to 30, and they were normal. So it depends on the number, and it depends a little bit on the context and the breed, I think.
Nick, it might be one there where you would think of diet and perhaps some of the kind of nutraceutical type things that have come out. I know Danielle Gunmore was speaking very highly of SAMI as it to be used particularly in cats. That seems to be her wonder drug.
Yeah, absolutely. Yeah, because I think at the very least, I think once you've proven that it's not got progressive disease and it's not in the level where you're likely to have problems of an encephalopathy. In other words, you're comfortably below the 90 to 100 level. Yeah, absolutely. Why not?
Great. We've got Richard Fox, who's from Abbey Veterinary Services down in Newton Abbot. He said, totally agree with you, Nick, about liver cytology. Good for screening, especially for lymphoma, lipidosis, and focal lesions, but cannot access architecture.
Yeah, and unfortunately, I think there has been a bit of a trend in the last few years, as people have got ultrasound machines and seen, weird and wonderful changes in the liver, to have a go at them. And I would say on a daily basis now, I do probably 4 of these, which we affectionately refer to as random stabs. And to be honest, the majority of them, we end up saying, it looks like those first pictures that I showed you of slightly swollen liver cells with vacuolar change. It's just not specific enough to give you a diagnosis.
We have a question, well, a statement here, which again, we actually had Clive Elwood give a talk on feline triaditis, and Keith says no mention of the Americanism triaditis. So I don't know if that's said in a positive or negative way. What's your thoughts on that, Nick?
I absolutely think triaditis is a real issue, and I think Sharon Center actually got it right with triaditis, because she said to investigate those, it's a big call. You have to go in, take intestinal biopsies, take a pancreatic biopsy, take a liver biopsy, and do cytology and culture on the bilirubin. And that's the way that you know you've got triaditis. And that's a really big ask, I think, for a client. So yes, triaditis is a real issue, but I think often we simply don't get that far down the track. But do I suspect it very often? Often I'll use PLI to try and confirm that I've got pancreatitis, and I'll use folate and cobalamin together with the liver changes and just put all of those together. But yes, I mean, that cat that I showed you with hepatic lipidosis, it also had pancreatitis. And as you know, that's about 40% of cases of cats with hepatic lipidosis have got underlying pancreatitis at the same time. They're well on their way to having triaditis.
Sophie's asking, do you always recommend blood samples being taken in starved animals, or is it okay to interpret as having just eaten a meal if tests during the initial consultation?
I think it depends on 2 things. I mean, I think the lipemia that I showed you can influence your results, and I think that's true of your in-clinic systems particularly. What we tend to do now is that we actually clear that lipemia chemically. We use a substance to actually get that lipemia out the way, and then we can still go ahead and assay it. So in that sense, the old problem that used to be that we couldn't actually do the tests is now done away with. I'm more than happy to look at samples that are not starved. I mean, in the real world, most people don't take their pets to the vet starved. That's how we all work. All I'd ask is that I know that it's an unfasted sample, and often that information is missing, and it makes it difficult to interpret bile acids, because as we've seen, it will be very different as to whether it's a starved sample or a postprandial bile acid. No, I don't have a problem with doing it. In fact, in some ways, it's helpful if we have got that, because then at least we know where we are with the postprandial bile acids. That's the one that's the known, rather than the basal bile acids, where you simply don't know how high it's going to go when you stimulate it.
Yeah. Kirsty has a quick question. Polydipsic dog with increasing alk-phos over several months, negative for Cushing's on ACTH and low-dose Dex. What should I do next, Kirsty?
Well, hopefully from tonight you sort of realise that we need more information than just the alk-phos. I mean, that's one of the take-homes of this, is that you need the full full profile. And in the context of polydipsia, remember I said your profile should tie back to the presenting signs. I'd want a urinalysis including the culture. Because in my experience, it's not uncommon that some of these dogs will actually have UTIs, particularly with E. coli, which, if you think about it, when you have a dog with a pyometra, why does it drink so much? Well, the reason is it's got an E. coli urinary tract infection, and those E. coli produce a toxin that blocks ADH receptors, and effectively they've got acquired diabetes insipidus at that particular point.
Yes.
And those urinary tract infections sometimes are not very obvious. And you can, if they're producing really dilute urine, you can look at it on a sediment, and you still won't see the bacteria or the white cells because they're kind of lies. They're diluted out in this huge volume of urine. So I'd say do a complete urinalysis, including a culture, as a kind of starting point, and expand your chemistry panel, see if your GGT is affected, and see what else is actually going on. So the canine urinary profile in our language would cover all of that, and you just need to add on the culture and the boric acid. All right, thanks again then.
Thanks very much, Nick. Take care.
Yeah.
Good night, everyone.